Good morning, everyone. If you're just joining us, we're just waiting for a few more attendees to enter from the waiting room and we'll get started. Thanks. Good morning, everyone, and welcome to MGH Brigham Global Health Grand Rounds. I'm Louise Ivers at Mass General Hospital. It's my pleasure to introduce our two really distinguished guests today. First, we're going to have a keynote commentary by Fatima Hassan. Fatima is a human rights lawyer and a social justice activist, and she's the founder of the Health Justice Initiative. She's a recipient of the 2022 Calgary Peace Prize for her work. This is an award to recognize individuals globally for their work supporting peace and making the world a more just, safer, and less violent place. She has dedicated her professional life to defending and promoting human rights in South Africa, especially in the field of HIV and AIDS. She's worked as a ministerial advisor and in philanthropy and in the nonprofit sector. She served on numerous nonprofit boards, is the recipient of many awards, and is often writing for local and international media publications. She's currently a board member of Global Witness, and she serves on the advisory group for Resolve to Save Lives. And we're absolutely delighted to have her join us this morning. A little later, as we get into discussion, we're going to be also hearing from an esteemed colleague here in Boston, Professor Brooke Baker. Professor Baker teaches at Northeastern University School of Law. He taught and consulted in South African law schools and law school clinics between 1997 and 2012, and is an honorary research fellow at the University of KwaZulu-Natal. Professor Baker is also a senior policy analyst for HealthGap, and he's actively engaged in campaigns for universal access to treatment, prevention, and care for people living with HIV and AIDS. Recently, he's been working on accelerating research and equitable access to vaccines, medicines, and diagnostics to respond to the COVID pandemic. He's written and consulted extensively on intellectual property rights, trade, investor state, dispute settlement, access to medicines, and medicines regulatory policy. He served as a key alternative board member and board member of the NGO delegation to UNITAID, and he's presently a civil society representative to the therapeutics pillar of the Access to COVID-19 Tools Accelerator. So I'm absolutely delighted about this discussion. And I would like to hand over the microphone to Fatima to begin her talk. Thank you very much.
Thank you, Louise. It's just really an honor to be invited to speak to all of you today. I'm really looking forward to the panel discussion with Joe and Serena and Brooke, who's a close ally and a good friend of mine for the last 25 years. And Brooke and I were just talking about earlier before the panel started about how we're telling the same story, right? The story that we told at the height of the HIV/AIDS crisis, we're telling the same story in COVID, and we'll continue telling the same story for cystic fibrosis or for any other disease, whether it's cancer or HIV or TB. So yeah, really looking forward to the next 30 minutes. And I think Louise is helping me with the slide prompts. So we can get the next slide. So I just want to start off by making sort of a few remarks, which some of you may agree with or may not, but my role here is to be a provocateur and to really tell you sort of what happened in the last 2.5 years, and particularly because the audience is made up of researchers who have been working not just in COVID, but prior to COVID on a range of diseases and illnesses, and really trying to, make science exciting and make science available. Unfortunately, that is not actually translating into reality on the ground. So what we had was, in this pandemic, we thought it was going to be slightly different. The history of access to medicines is one of not having timely access, not having fairer access, not having supplies when you need it the most at a price that is affordable for most people in the global south, where I come from, Africa, and obviously because of our apartheid past in my own country in South Africa, it was really based on race. And more recently, it's been based on nationality and proxy. So what we thought was going to happen in COVID was slightly different, because everybody stood up on global platforms and said, this pandemic actually affects everybody around the world in the same ways and at the same time. So when your borders were closing, our borders were closing. When you were going into lockdown, we were going into lockdown. It's very different to the HIV/AIDS crisis because this kind of happened simultaneously across the world, affecting billions of people at the same time. So these global leaders all stood up on these platforms and said, we're going to offer solidarity. And whoever finds the vaccine will share it, right? None of us thought that there would be an accelerated entry of vaccines into the market. I mean, we all assumed that you'd have diagnostics and maybe you'd have therapeutics. But what happened was when the first clinical trials started basically progressing, and a lot of scientists worked, day and night, 24/7, to basically made significant progress, and they're supported by a lot of funding from governments in the global north and specific philanthropists and different types of programs. When we were offered solidarity, the total opposite happened. And this is why, as activists, we've said in this pandemic, solidarity was just the word. Because two things happened to basically suggest that our lives mattered less than people in the global north. The first is that even though we were promised solidarity and that we would all share in whatever supplies there were available in the global market, first for healthcare workers and then for people who are over 70 and for people with comorbidities, that didn't materialize. Because richer nations, including those nations that have funded vaccine development programs like Operation Warp Speed or the German government, for example, or the British government with AstraZeneca, basically pre-ordered and over-ordered, and that's what we call over-ordering and hoarding vaccines, and then bypassed the mechanism that they said would be set up to provide vaccine equity for the world, and that's called COVAX. The Lancet's called it a beautiful idea that fell short. MSF's called COVAX a broken promise to the world. And we mention these mechanisms because if this is going to be offered in the next pandemic as a solution for equity for people in the global south, then this is not the mechanism that we want. We would prefer a model of self-reliance. The second thing that happened was that the EU and the US government and others outside of the EU, including the UK, blocked a proposal for temporary IP waiver, and we'll come to that later in the presentation, and instead suggested their own solutions, which was quite opposite to what people in the global south actually wanted. And new evidence has now emerged, and there's new media reports, particularly by Politico, that have suggested that in many respects, these governments deferred to the lobbying and the interests of pharmaceutical companies, and then tried to cover this up by relying on donations. In our assessment of what has happened in the last 2 years, solidarity was just a word, and there really hasn't been any kind of effective solidarity. Next slide. So, when we're talking about cystic fibrosis before this panel, I mean, we can even just go back 20 years ago, because Brooke and I, whenever we speak to audiences like this, we'll say that we've been here before and we know what needs to be done, but there just doesn't seem to be the political will or the political action necessary to deal with this. And that's why we thought with COVID it would be different. But at the beginning of the 2000s, I mean, I was living in a country where 600 people were dying every day because of HIV infections, which were preventable. And there were ARVs that was available. There was the fruit of scientific knowledge that was not being shared because generic entrants were not actually permitted. And the price of ARVs at that time, particularly first-line regimens, was so prohibitively expensive that it meant that only the rich could basically access ARVs through financial insurance schemes or what's called medical schemes in South Africa, or basically if they had a very wealthy sponsor. And so the irony of what happened with HIV/AIDS was that despite the number of people that were affected by HIV, despite the fact that ARVs were available, despite the fact that there were local manufacturers, or what we call manufacturers in the global south in multiple countries, that could assist with manufacturing more ARVs to introduce generic versions and even competition into the system, so you wouldn't have to rely on a single ARV manufacturer. People still died and people still could not access ARVs, despite, in many cases also with ARVs, significant public investment and funding into those medicines. The next slide, please. So, what we thought was going to happen didn't. We imagined was going to happen. Solidarity in a global pandemic, sharing of technology didn't. Instead, what we saw was hoarding. And what I've written about before is that the hoarding wasn't just of vaccine supplies. The hoarding actually had 3 different elements to it. And this is what we're seeing in crisis after crisis, in health condition after health condition. It's not just about the supplies being shared or being distributed equitably. It's also about the scientific knowledge that you as public researchers or public scientists contribute to, as well as the hoarding or control of supply chains and what we call licensing arrangement. So even if we were to set up a mechanism that had sufficient vaccine supplies that shared it equitably with the world, we would still need to address the second and third element, which is how do you actually share the scientific knowledge in a more equitable way, in a way that actually encourages genuine technology transfer? And we'll talk about the mRNA hub later in the presentation. And also, how do you open up the supply chain to ensure that the licensing deals not just with fill and finishing, but the full manufacture of health technologies, and in this particular case, we were talking about vaccines. And when you hoard all three elements, and there's probably other elements of hoarding that are also relevant, but for me, these are the three key ones. What it does is it creates one-sided power in a pandemic or beyond a pandemic. In fact, it creates monopolies, right? And we saw that with the Pfizer monopoly or with the Moderna monopoly or the AstraZeneca monopoly. And those monopolies were playing out sometimes simultaneously or at different times throughout the pandemic as new variants were being discovered and as different vaccines or bivalent vaccines came onto the market. And, you know, it's a really fascinating story that one day somebody is going to have to write about the timing of when these vaccines went onto market, when they were procured, and when they were actually supplied. Because if you look at the beginning of 2021 and the end of 2021, the vaccine selection and decisions around which vaccines, which countries were going to use were dramatically different because of the pace of an accelerated research that happened within the space of 12 to 24 months. And then the second thing it creates is very little transparency, and I apologize for the typo in the spelling there. And thirdly, it creates unprecedented control on the parts of pharmaceutical companies. So what we saw in the COVID pandemic, and we saw that also to a lesser extent in HIV/AIDS, is that despite public funding of clinical trials to accelerate vaccine research, to get the entire world out of this pandemic at the same time, that was the theory, the idea behind solidarity, that even the clinical trial design and the post-trial benefit sharing agreements were actually controlled and decided upon by pharmaceutical companies. So even the quantity of supplies, where they would go to, who was the preferential customer, separate from the pricing issue, those were decisions that were actually not in the hands of government, which one would imagine should be, not in the hands of the researchers that had actually put that science onto the table, but actually in the hands of CEOs of pharmaceutical companies, which is why many of us argue that they were actually playing God in the middle of a pandemic. Decisions around equitable allocation, we believe, should be made by a body like the WHO. It shouldn't be the CEO of Pfizer deciding, well, first I will send preferential supplies to country X, and then only when I think that the global north has been sufficiently vaccinated with 1 or 2 shots, then I will start sending supplies to countries in Africa, or in some cases, I refuse to supply certain markets. So it creates control over the market in ways in which are not transparent, and which actually, in my view, undermines sovereignty. It creates a lot of power in the pandemic, which is one-sided and unregulated, and like I said earlier, very little transparency and accountability. The next slide. So I always like to put the slide because I want to remind people that even though the travel restrictions have been lifted and maybe you've got your 4th or 5th dose, I don't know where you are in the US with your program, that there's been a lot of suffering and death. So when we used to talk about the HIV/AIDS epidemic, we talked about those deaths and the suffering in the space of a decade, of 10 years. And what we really have in COVID, and I think people forget this, is, and we need to remind, I think, the global health community that in the space of 24 months, that's only 2 years. The WHO estimates that excess death, and I mean, you all know what that means, is about 14.9 million. And this was at the end of November 2022. So the number is slightly higher now. And yet, based on what we're going to talk about in the presentation later and what I've talked about earlier, these deaths could have been mainly prevented or mostly prevented, even though we're talking about excess deaths and they could have been indirect causes. But if you had vaccinated the world at the same time much earlier in all parts of the world, and I'll show you the heat map of where the vaccine went and where they are not, then I think the situation would have been very different. But either way, what you're dealing with is a massive global pandemic with devastating consequences, with millions of people who have actually lost their lives. Next slide. So if you I updated this yesterday evening, but if you look at our world in data numbers, and we've been following it since the beginning of 2020, and you'll see how the colors of these maps have been changing. They don't really change that much for Africa over the last 2.5 years. But be that as it may, we have a situation where let's say 27% of people in low-income countries have received at least one dose. So that, I think, is actually quite shameful if you're looking at where we are in this pandemic, where we could have been in this pandemic, and how we could have dealt with issues much differently. Now, this is not to suggest that this is only because of a lack of supplies or a lack of technology transfer. I mean, I think there's various other political as well as disinformation factors that exist that explain this. But the startling kind of color variations from Africa to other parts of the world, I think, is really cause for concern, because this is how future pandemics are going to play out, and this is how future access to treatment programs are going to play out for other diseases. If we get the next slide, and I always like to show these maps because later in the presentation, I'll show you the countries that are most vaccinated or received vaccinated early on were also the ones trying to block efforts of the global south to try and create the self-reliance. So the map is actually quite a useful indicator. But here you'll see sort of where the world's unvaccinated people are according to our world in data. And it shows, I mean, I think obviously some concerns around what's happening in the US and in parts of Latin America. And, you know, if you factor into conflict and war situations in Russia and Ukraine. But if you look at the number of places, the heat map in Africa, again, this is an issue around the fact that when it mattered most, when we really needed vaccines, including in my own country, I waited 8 months before I got my first vaccine. I think by that time, Brooke had already got his second dose. Or my mom waited much longer, who's of similar age to Brooke, before she could get her vaccine. So I'm just giving that as an example because we all could have been vaccinated in a timely manner at the same time, but we just waited months and months and months. And the irony of what was happening in South Africa at that time was that Johnson & Johnson had asked one of our companies to actually fill and finish vaccines. And we found out a few months later that they secretly were being sent back to Europe because European countries were the priority customers at that time for J&J. While we were actually waiting for vaccines and we were actually going into wave 3, and that's been reported in the New York Times. So this map, I think, gives you an indication of the problem that we have about, and for me, that problem is two things. How do we convince people in the global south, that science is actually useful and that scientific knowledge can actually mitigate premature death and suffering? And then how do we also, so that deals with disinformation and dealing with growing anti-vaccine movements and anti-science movements. And then also how do we convince people, if we can access sufficient supplies, to now vaccinate 3 years later after most parts of the global north have already received 3 or 4 doses. The time when we could capture people into a cohort, when we could convince them to take the first dose or second dose, was in the early part of 2021, when we were literally waiting for supplies, and the only supplies that were coming in were through small donations. COVAX was not delivering, and a drip feed of supplies from, in the case of South Africa, for example, Pfizer and Johnson & Johnson, but not sufficient to actually have a mass vaccination program to create a dent into the pandemic. So supply chains, timing, pricing, despite the best scientific knowledge that there may be, despite trying to enjoy the fruits of knowledge, it's not always going to be possible. The next slide. So, this is just an indication of the early days of the amount of money that had actually been put into some of the early vaccine clinical trials. And it's always useful to put it up because it, indicates the early numbers, which are running into billions and millions. These numbers have been updated as we've been able to get more information, but because many organizations had to use access to information requests, particularly in the US, to try and truly establish what the actual cost was to accelerate vaccine research and how much money was actually invested through the public. This at least gives you a preliminary sense of it. And this is actually what led to the People's Vaccine Campaign being established, and this idea of a global public common good, the idea of a people vaccine that needed to be shared. It wasn't just that it was the right ethical thing to do. It was also that significant amounts of philanthropic as well as public funding through government sources were actually diverted or directed towards these clinical trials to enable scientists to do the work that they did. The next slide. This is just a snapshot to show you, when I talked about when it mattered the most, we didn't get the vaccines. When we waited in early 2021, we started January 2021 with this kind of scenario where, like I had mentioned earlier, COVAX was unable to secure enough supplies. It was not able to meet its equity needs. And when countries in the global south went to the front-runner vaccine manufacturers who had already brought their vaccines onto market through emergency use authorization or through normal regulatory approval, the doses had already been offered to countries like the UK, the entire EU bloc, the US, Canada, and Japan. And what they did was they basically hedged their bets. Gavin Yami, myself, and Kamran Abbas have written about this in the British Medical Journal. So when we talk about clearing the shelves and no supplies left for anybody else, I think this just gives you an indication of what was happening in the early days of 2021, which I think had the significant negative impact on the ability of the world to actually vaccinate billions of people at the same time in the same time period. The next slide. This again just gives you a sense of what was actually happening in terms of the over-ordering and what we call the hoarding. That then had the consequence of the over-ordering and the hoarding meant that when countries started using mRNA-based vaccines or mRNA platform vaccines, or were using a different vaccine regimen, the vaccines that were not wanted or that they didn't want or that they had too many of were then on very short notice being sent to countries in the global south under the pretense of vaccine equity and donations, which we all know is, had its own set of problems. The next slide. So Louise asked me to explain to you why all of this matters, because you can do the most brilliant, amazing, beautiful science. You can do it for a government, you can do it for a philanthropist, you can do a lot of public funding, you can design it in a way where communities are involved in the clinical research, but what happens after, right? Because there's very few, and there's, rare examples in history of having a beautiful invention or innovation that is actually for the public. The polio vaccine, maybe. There's a new vaccine in Texas that has a royalty-free licensing arrangement. But by and large, the way patent monopolies work, whether it's vaccines and COVID, ARVs during the HIV crisis, the current situation with Vertex and cystic fibrosis, is that the patent protection by in itself, and our colleagues in the US, Health Gap, as well as CHI, as well as IMAC, have written about how the US patenting system allows these exclusive patent monopolies to emerge and actually to be long-standing. And so what that then does is it limits the number of companies that can make generic equivalents. And what we saw in the COVID crisis was the patent protection and the patent monopolies, where these CEOs were paying God, meant that they refused to share the technology in a way that would allow companies in Africa, as well as in parts of Asia and Latin America. The New York Times did a story where they found 100 possible partners that could actually have sped up the production of vaccines for the rest of the world at the same time. Data exclusivity is another key barrier. And Brooke can talk about that, I think, a bit more in the panel discussion. But the other consequence of patent monopolies, which is enabled by patent protection, and in some cases, what we call evergreening, so the patent protection just goes on for 20 years and then 30 years and 40 years and 50 years, is that without any kind of regulation of pharmaceutical companies, due to the patent monopolies and the lack of price competition, or what you would call antitrust, what we would call anti-competitive measures, it means that the company can charge whatever price it wants to, like it already does for ARVs and cancer medicines. And if the contracts that are entered into in the middle of a pandemic are secret, where only journalists through leaked versions can find out what the prices were for the same vaccine, different companies in different parts of the world, then I think you have an additional problem, because there's no transparency on what was the actual R&D cost and how much does it really cost to bring a vaccine to market in a pandemic, and why are we all being charged different prices. So pricing becomes an issue, which artificially high prices and the scarcity that you create through the patent monopolies becomes a key barrier for us in the global south. The next slide. Okay, so I don't want to go too much into this slide, just to say that when we talk about vaccine nationalism and the system and the conditions that gave rise to it, it's obviously about more than just patent monopolies and rights. So, we've dealt with some of the IP issues, but there's multiple elements to what is happening around intellectual property, that it doesn't just limit itself to what's happening around a patent or which invention is actually being patented. There's issues around background technologies, foreground technologies, manufacturing know-how, trade secrets around clinical data, transfer and licensing. And all of those elements were actually dealt with in what's called the TRIPS waiver proposal, which I'll talk about shortly. I've talked about the self-created scarcity and the over-ordering through bilateral agreements and the undermining of mechanisms such as COVAX, which also, in a way, had an impact on API source limitations and restrictions. And I think Brooke can also speak a bit more to that. So generally, what you had in this situation was, despite global leaders talking about vaccine nationalism from the global south, despite the offers of solidarity, despite the fact that so many people were dying, people were getting sick, the economic impact of this global pandemic, you just basically had companies in the driving seat refusing to open up science through opening up licensing. And so that's what we talk about, non-exclusive global licenses in a pandemic. We also had companies who basically initially refused to participate in COVAX, or eventually when they did agree to participate in COVAX, they came in with very limited supplies and kind of ring-fenced that. And the WHO CTAP basically had no manufacturer participation. It had some government participation, but often when we speak to scientists and researchers, they say, but why didn't world leaders try and pool all of this knowledge, pool the science, incentivize these companies, give them a reward? Well, there were efforts to do that, but the industry basically refused to participate in that and wanted to basically have their own exclusivity and make all of the supply and pricing decisions themselves. The next slide. So to address initially the TRIPS waiver, or what's called the TRIPS waiver proposal, and Louise asked me to speak about this, was that we didn't know that there was actually going to be vaccine nationalism. We thought, okay, there's a risk of it, but all of these people have stood up and they've spoken about solidarity, and so things will be different. We have flexibilities, or what's called flexibilities in the TRIPS agreement. Of course, we won't have a repeat of the HIV/AIDS crisis. But just in case, what the South African and Indian government did in October of 2020 already, this is before any vaccine has been approved for use in humans outside of clinical trials, right? Is that they asked the international trade body, which is called the World Trade Organization, the WTO, basically to have a temporary relaxation on the enforcement of intellectual property rules for the duration of the COVID-19 pandemic and for all technologies. So that would include drugs, vaccines, diagnostics, equipment, ventilators, etc. So it wasn't limited to vaccines, it wasn't limited to therapeutics, it wasn't limited to diagnostics, because at that time in October, nobody knew actually what was going to be sort of first on the market and what would make a dent in this global pandemic. And importantly, it was asking for a relaxation of all IP related to COVID-19 technology, not just patents, but for trade secrets, copyright, industrial design. And in the panel discussion, we can explain why that was relevant. And I've spoken before about how there was just such an intense lobby to block it, despite considerable support from almost all countries in the global south and a lot of influential thinkers, economists, trade unions, and the church. But despite all of that support, the global north still said, no, we refuse, to vehemently oppose, and opposed by the pharmaceutical industry as well. So this for us was also in the process. We can talk about it and what happened in that 2.5 years of trying to lobby, and Brooke and I worked with many others really hard to try and support the idea of the waiver. Was what we saw is, I think, the worst of global north double talk. Because on the one hand, they were talking about solidarity and how we need to open the borders and basically get a sense of normalcy. But on the other hand, the mechanism that was being proposed by global south countries was being basically ridiculed. And we were told that that's not what you need. What you actually need is more donations, and what you need is, you need to have your disinformation program. The problem is with you, the problem is not with the system. So I'm coming to the end of my presentation. I'll just take the next slide. So I have no words about this slide. If you remember the red slide and you remember the green slide and you look at this slide and you look at which countries were blocking this idea of relaxing IP in the middle of a devastating, deadly global pandemic, and which countries were supporting it, it almost correlates with the places where people got their vaccines first or where people are still waiting for their vaccines. The next slide. I don't want to go into the detail about the decision of the WTO, what we call the weak deal. Brooke and I have written about this. This is an extract from an explainer that we've done. If you're interested, you can look at an FAQ on what the decision means. But basically, it means very little. So at the end of 2.5 years of fighting, lobbying, negotiating for a decision around this idea of the temporary TRIPS waiver, what we got was a tiny little small decision that basically just lifted a restriction on the number of exports, a deal that is only limited to vaccines. They're still deliberating, 3 years later into this pandemic about diagnostics and vaccines. And basically a so-called solution which was celebrated by the EU and the US governments, but for us is really, frankly, quite meaningless, actually. It really didn't deal with the big systemic barriers to access to COVID technologies in this pandemic. And this is a concern because it means the next time you develop and you do all of this work on a really great scientific innovation, if a patent monopoly exists or if a government chooses not to share their technology, then most of us in the global south won't see the light of it, and we won't be able to benefit from the science that you are doing, often the science that you are actually trialing on us in South Africa. So we did 4 vaccine trials, and we were told that we could contribute to scientific knowledge, and we would get ahead of the queue for Johnson & Johnson, for Pfizer, for Novavax, for AstraZeneca, but the total opposite happened. That didn't happen. I think the next slide may be the last or final slide. And then the next one. I mean, if you want to read about who killed the vaccine waiver in your own government involvement, I would urge you to read this Politico piece from November. The next slide. It was deliberate, right? So, Louis, will you give me 5 minutes just to talk about the mRNA technology hub? So with all of this happening in the context, and sorry for taking so long to try and explain to you what happened in the last 2.5 years, the one possible silver lining out of the story of greed and out of the story of not sharing science in a timely manner for the Global South was that the WHO and several governments in the Global South said, well, that's it. We're never going to get the cooperation and the level of trust we need from the industry and from global North leaders. We're going to have a situation where we're going to not be in a self-reliant position if we continue relying on what's called northern mechanisms for sharing of science. So what we're going to do is actually set up what's called the mRNA Technology Transfer Hub program, which currently has about 15 spokes. And for some other reason, and it's largely related to the work that the University of Witwatersrand and University of Cape Town was doing on the mRNA platform vaccines, that they would actually set up the main hub in South Africa. And it's regarded as quite a radical plan for vaccine equity. There's been some mini breakthroughs made already. The Moderna has said that they won't enforce patents on the COVID part of the work of the hub, but not for any other work. And really the gem in this hub that's sitting in Cape Town is the collaboration amongst researchers and scientists from all around the world, including the 15 spokes, but the work that the hub is doing on TB, malaria, and HIV, and possibly even cancer later on. So if I get the next slide, I just want to show you some of the hubs where they're situated, which you can find on the Medicine Patent Pool's website or the WHO website around the Technology Transfer Hub. And then the next slide basically just shows you what CEO of Moderna has said about this great Global South effort to have technology transfer sharing across southern countries to actually create a situation of self-reliance for a whole range of diseases using mRNA as the platform. That it's basically like copying a Louis Vuitton handbag. And they basically have filed patents in South Africa and are reserving their rights to potentially hobble the efforts of the hub. So if we get the next slide, which is, I think, the final slide, this is what the overnight billionaire, the CEO of Moderna, one of the most profitable products that Moderna has basically claimed is theirs. We still call it the people's vaccine because of the amount of US funding that went into the research of this vaccine. There's a current legal dispute in the US. But this is what he said about the mRNA hub and about the work of scientists and researchers in the Global South at the hub. Thank you.
Thank you, Fatima. That was an extraordinary talk. And I think ending on the Louis Vuitton handbag is a very, very disturbing image that certainly will never leave me. Brooke, we were wondering if you could just make a few comments before we start the panel discussion.
It's always wonderful to follow Fatima because she covers so much and so clearly and with such passion. I think that, again, given our audience, a big part of what we're hoping to convey is that all the hard work of scientists ends up being under monopoly control, and that monopoly control has very significant impacts on equitable access. That's a story that Fatima's told you about vaccines. As a law professor, and Fatima actually in her prior work, we focused as well on human rights perspectives. And of course, everyone knows the human right to health, but the human right to health has an aspect of it that explicitly covers the right to access to medicines and other health technologies. But as well, very important for researchers like many of yourselves, there is the right to the benefits of scientific application and its scientific progress and its applications. This is an area of human rights that probably doesn't get enough attention, because what it really says is that scientific progress is built on the backs and shoulders of a very broad scientific community with huge degrees of support from public sources and from the people who end up volunteering to be human subjects for clinical trials. And that it typically, brings great promise of benefit when it's actually reaches the applied stage, and that needs to be shared. It's not to be commodified the way it is. It's certainly not to be monopolized the way it is, but that's what ends up happening. So partly what we would hope to convey to people who are listening in is the most basic human rights framework that emphasizes that the work you do is to be shared with the world and not subject to the artificial monopolies that are created by governments initially, but then defended by huge displays of corporate power. I want to put a couple numbers on the table, maybe to flesh out what Fatima was talking about. So I want to talk just a tiny bit about the money that has been made by Big Pharma during this pandemic. The recent reports of the profits from the sales of vaccines and therapeutics in 2022, $100 billion. 57 billion of that to Pfizer alone. Now, let's just think about that. If we took the amount of money that was actually invested in the global response for low and middle income countries through the Access to COVID-19 Tools Accelerator, of which COVAX was a part in the vaccine stream, that got a fraction. It got basically 25% to 30% of what the drug companies took in. So they made this huge amount of money on these products. The products are usually, in terms of a cost basis, 1/10 or 1/20th, and sometimes even higher than what they're charging. So the fact that there's monopoly control means that, as Fatima said, several things. They can artificially restrict supply because they maintain control of supply through their own manufacturing facilities, artificially high prices, and profiteering. I think everyone would agree that $100 billion earned by pharmaceutical companies alone in the middle of 1 year of the pandemic is hugely excessive. And then they get, as Fatima said, to control the distribution and to favor rich countries with cash in hand who can enter into agreements in advance and that are powerful demanders. And they can then allow them to stockpile multiples of what their population need. I'd like to mention something else that Fatima touched on, but I think is also very important to researchers. The companies end up controlling clinical trial design, and Fatima did mention that. But it has very important consequences because the design includes which populations are studied. More importantly, sometimes which populations are excluded. Are pregnant people excluded? Are people with TB excluded? Are elders excluded? Are other people with comorbidities excluded? Are children excluded? Because to the extent they are excluded, then of course, the benefit of scientific progress is delayed in reaching those other populations that aren't studied. There are restrictions on what are called comparative studies and studies involving regimens. Particularly in the therapeutic area, we know that developing regimens for a virus that mutates quickly or bacteria as well in some instances is incredibly important. So the idea of being able to develop regimens as opposed to single therapeutic products is very important. And we know that access to trial drugs is very important for studies. And we actually know that some of these companies have refused to give access to trial drugs and or charge very high prices, which again limits scientific progress. I'd like to emphasize another kind of barrier besides intellectual property barriers, and Fatima did mention patents, which we all know about, but then trade secrets critically important for complex medicines and products like vaccines and biologics. The very detailed production and quality control information to produce at a commercial scale is hugely valuable to companies rather, and has an endless monopoly unless it's reverse engineered in some way. And so that's why Moderna could say, well, it was not going to enforce its patents, but they had no meaning in expanding access because the commercial know-how about how to put together a production facility was unavailable. And that's now what the messenger RNA hub in South Africa is having to recreate over a 2-year period, is that commercial scale know-how basically building it from scratch with the assistance of many people globally who are helping it. But another important aspect beyond the intellectual property rights is also companies' control over registration, where they will try to even put the product on market. And we know historically they have preferentially registered in rich country markets, the US almost always first, because that's where it makes the companies make the most money, but then also thereafter in Europe. And almost always the smallest and poorest countries are left behind and may never have the product registered there. And that's certainly been a problem with respect to the antivirals, Paxlovid and Molnupiravir in the present circumstances. So I think one other thing I'd like to mention very briefly, and again, I think it was implicit in what Fatima was talking about, and much more important in terms of the kind of research you do. Those of us who work more on trying to ensure that there's access to medical products for people in the global south know that we have to have products that are well adapted for use in resource poor setting. And a lot of medical research is focused on, from that perspective, products that may have extra bells and whistles, particularly in the device and diagnostic sphere. And without that much attention to heat stability and method of administration that are not problems as much in the global north, but certainly are problems in the global south, and particularly with respect to reaching rural populations. And so, one of the things we always like to talk to when we're talking to researchers is the critical importance of that incremental innovation, that extra step that's needed to transform products so that they are of use in resource poor settings. And as a clear example of this problem, we saw the super refrigeration requirements of the earlier mRNA vaccines and the added burden that put on the possibility of distribution in countries that simply didn't have one of those freezers, let alone distributed throughout the country. So I want to stop because I'm sure there's questions from the audience and from our moderators, and so please carry on.
Thanks so much, Brooke and Fatima. Can I start with if I could take the time to start with a question for both of you. That was a great, thank you so much, Fatima. That was an incredibly illuminating talk. Do you have any thoughts about eventually, hopefully over the next 2 years, COVID will become under a little bit more control. There'll be more immunity, but there'll be another pandemic, as we all know, right? 10, 20, 30 years in the future. What do you recommend happens between now and the next pandemic to ensure this isn't, a repeat of HIV, a repeat of COVID? And where do you think the political will for that movement will come from? I know that's an easy question.
Well, very quickly, as people may be aware, there are negotiations at the World Health Organization to revise international health regulations, but also to create a pandemic preparedness and response treaty that is a binding agreement to address future pandemics. Unfortunately, we have a situation where Big Pharma continues to say, and has done so in something called the Berlin Declaration, that IP must be protected because that's the basis of the incentive system that allowed them to make $100 billion a year in this pandemic, and that's what created the speed of progress that we saw. And they say, well, that will be enough. Protect our IP, indemnify us against any harm caused by our products that come to the market, create a global purchasing fund, and we will finally agree to put some more product aside for low and middle income countries. So they want a voluntary solution where they maintain their intellectual property rights and all the control that they had before, but say that this time, if you have cash in the barrelhead, we will not put low and middle income countries at the back of the line. They'll be, they'll be somewhere, they'll get earlier supply. So that's the what's being proposed by industry, and that's largely what's being proposed and supported by the European Union, United Kingdom, Switzerland, and the US. In other words, the rich countries where the products came first and foremost, they're satisfied largely with the IP system as it is, even given the global risk that were created by that system. So there's a lot of work to be done in those negotiations to try to say we need more than that. We need something like the waiver system that was originally proposed by South Africa and India for future pandemics. And we have to have research funded publicly and much less controlled by big pharma along the way to develop the platforms that will be needed for quick responses in terms of promising vaccines and therapeutics. Now, one of the main platforms is the messenger RNA platform, which at least for vaccines, but potentially for other uses is very important. So that's a big place to focus our attention. Certainly is with the pandemic treaty. But Fatima and I have also worked extensively to try to get governments to act on their own behalf. I mean, the international TRIPS agreement that sets up the minimum standards for intellectual property rights and national legislation all create and protect these IP monopolies, but they have flexibilities. Governments can force the sharing of technology. Governments can override patent rights. And we think countries really have to start acting more on their behalf. If you sit back and wait for something to happen in Geneva, if you sit back and wait for the benevolence of Moderna and Pfizer and the other companies, you've got a very long wait, which is what we discovered. And the wait causes lives to be lost. So we're really promoting the idea that Southern governments need to act in their own behalf to use flexibilities that they have, including something called compulsory licenses, which allows for generic production. They need to have rules that allow overriding trade secret protections. And even more importantly, they need to act in concert. So the countries that are excluded from voluntary licenses that have been granted to the medicine patent pool, for example, we think those upper middle income countries should act in concert. No, we're not going to let Pfizer charge us $280 a course of treatment for a product we could get generically for $25 for a course of treatment. We're not going to be held over the barrel. We're not going to be blackmailed in that way. It's really not even blackmail because they can't pay the ransom. There's thus far in all of Africa, 10,000 courses of treatment of Paxlovid have been delivered. That's it. I mean, we've had Paxlovid for a year in the U.S. I've taken it. I assume other people either watching or on the panel have had COVID and gotten quick access to Paxlovid. But imagine yourself on a continent where there's essentially none. And those are the realities we have to overcome through country action and whatever we can get out of the World Health Organization and of course, continuing efforts at the WTO.
Thank you so much, Brooke. Stanley has a question for you. Thank you for this great presentation. Listening to you all, one cannot help but conclude the main issue is political. How can the scientific community help decision makers understand how, for instance, delaying vaccines for the global population keeps their own constituents at risk, especially countries with aging populations that are more at risk?
Well, that's the one that's really got us scratching our heads. It's hard to believe that our governments are so protective of big pharma and so relatively inattentive to public health and the health of populations. And frankly, of people my age, I'll be 76 this month, and live at constant risk of second round of COVID. And with adverse consequences, let alone what we all now know about long COVID and its devastating impacts on well-being and social participation. So, unfortunately, pharma has the ear of our governments. It's almost like they have a sitting room next to the living room, of our governments, and that they can kind of walk in any time they want. And they often, in the US, bring lobbying money with them. And they've convinced rich governments basically of the fact, we'll take care of you first. Okay. And that's what happened in this pandemic. The US always gets first crack at new products. And, we're a rich enough country that we can almost afford things. But even now we're finding that with the new biologics, it's simply unaffordable for the system. And there must be people who are clinicians who are listening in who feel real frustration that sometimes there are patients you have that's very hard to get money, get the necessary products for, including for some of the rare diseases. So I think it'll take much more attention from researchers and clinicians to governments to really bring home the human consequences and the health consequences. And frankly, what I would think would be a demoralization to the scientific community and medical community, that all your hard work, the countless hours that all of you put in, both as researchers and as clinicians during the pandemic, the time away from families, the heartache that you were exposed to, and the fact that that's kept circling back because the system wouldn't vaccinate the world, and kept circling back with new variants because people could not get treatment. I would think the anguish of your voices and the urgency of your message could help. And for example, one thing you could think about right now is the U.S. International Trade Commission has been compelled by the United States Trade Representative to investigate whether the waiver should be extended to therapeutics and diagnostics. And they're accepting evidence on that question. So I think the evidence you could bring to bear about how important antivirals and other therapeutics will be, not just existing ones, but potential future ones, to responding to the pandemic, to preventing hospitalization and death, but hopefully, as we also know, potentially preventing the development or severity of long COVID as well. And so, I think there's lots that you could bring to policymakers about the urgency of the situation.
And if I could just add there, Savannah and Joe, one of the things we've been working on is, in the same way that we got the scientific community and researchers really to support us in the HIV/AIDS movement, is on COVID and any new technologies, there has to be a reckoning and a conversation about clinical trial design. So the delay from post-trial conclusion to a decision around a dossier submission, sharing of the dossiers, and designing a trial in a way that there has to be some guarantee if there was public investment or public funding, that there has to be conditions around no geographical restrictions around where that product can be used, in the way that Pfizer has decided that some people get Paxlovid and some people don't. We spend all our money on vaccines, so we can't even afford Paxlovid. But if you want to get it from the private sector, it only got approved last week, Friday. So the dossier submission timing, there's no requirement on the company that sponsors a clinical trial to submit it within a reasonable time period. They can create geographical restrictions, but Moderna decided it just didn't want to supply vaccines to South Africa or many African countries, even though it found its patents here. And the only community that can insist on post-trial benefit sharing agreements is the scientific community. Stop doing clinical trials for big pharma if those products are not going to be available for use for people in the global south. And this is a situation we had with VOTE, with Kevlar. Kevlar was tested and trialed on people in Brazil and in South Africa. And what happened when the trial was concluded and the evidence was there to suggest that it could be really a revolutionary way of managing HIV infection? We were offered a really high price and no generic entry until activists and scientists and researchers stood up and said, well, this is not going to be okay. So the terms and conditions, I think it has to be enforceable. I really think you can't, rely on the benevolence. There has to be a demand there. early in the pandemic, when we had the CROI conference, remember, Louise, Greg and I spoke at that at the plenary, and we got over 100 scientists to sign on to a declaration for vaccine equity. So I think there's an appetite there of the scientific and clinical community. The question is going to be, is there enough of a group of scientists who are the leading scientists in the world and leading researchers in the world who say, we refuse to do this trial because you, Pfizer or Viv or Vertex or Moderna or Johnson & Johnson are not ensuring equitable access and timely access for people in the global south. And just on the question of political will, I mean, it's true what Brooke is saying, that there's really political inaction amongst many global south countries. They put all of their eggs into the TRIPS waiver basket and didn't take, the necessary domestic action. But just remember that when we do try and take action, when you do have a strong enough politician that actually decides to take on the pharmaceutical industry or Biden's administration or the German government, the first thing that happens is that the pharmaceutical industry, which is reflected in that political piece, creates threats and pressures, not just on our country through trade pressures and trade sanctions, what happened in HIV/AIDS when the US government put us on the trade watch list, but it also threatened governments in the north with disinvestment. And that is what happened with the Belgian government and Johnson & Johnson around the Belgian government's position on the TRIPS waiver. So it's part of such a complex system of political and trade factors and threats that we're going to have to chip away at this, I think, in small bites, in small bits and pieces. Yeah.
Thanks, Fatima.
Well, I think that unfortunately we are out of time for this morning, because I think we could talk about this and we should continue to talk about this. We're really grateful for both of you, Fatima and Brooke, for joining us today, helping us understand better and calling us to action. So thank you so much.
Thank you. Bye. Bye, Brooke.
Good to see you.